ELSA Outreach Program Basic Laparoscopy Workshop of 2025. While we wait for the rest of our participants to join us, please feel free to make yourselves comfortable. We have refreshments and coffee prepared for you at the side and at the back. Do enjoy them while we get ready to begin. This is also a great time to recharge and maybe mingle a bit with your colleagues before we officially start the program. Thank you. Workshop of 2025. Yesterday, we had a full day of lectures and hands-on training, and even a thrilling laparoscopic suturing contest. Today, we continue with another exciting program focusing on surgical mastery through video demonstrations and live operative experience. Let's all settle in and get ready to begin. Up first on today's agenda is our video masterclass, where we'll see step-by-step demonstrations of key laparoscopic procedures from our distinguished faculty. We begin with diagnostic laparoscopy, presented by Dr. Chris Daniel Parilla. He had his fellowship training in upper GI and bariatric surgery, endoscopic ultrasound and advanced endoscopy, and fellowship training in surgical endoscopy and minimally invasive surgery. He is a training officer at Cebu Doctors University Hospital. Let us all welcome Dr. Parilla.
And Center's view na din. Di mo parang ano?
Once again, let's give a warm welcome to Dr. Parilla.
Hi, good morning, and thank you for that kind introduction. So I would like to thank the organizers, especially our mentor program director, Dr. Henry Chua, for this privilege. So I am tasked to present a lecture on or a video masterclass on diagnostic laparoscopy. But before I tackle on videos presentation, I'll touch a bit more on a short lecture about diagnostic laparoscopy. Since this is not quite common in or commonly presented in basic laparoscopy workshops or lectures. So the objective of this topic at the end of the session is each participant will be able to explain the indications and contraindications for diagnostic laparoscopy and the preparation needed for the procedure, able to differentiate between limited diagnostic laparoscopy and extended exploratory diagnostic laparoscopy. So for the indications of diagnostic laparoscopy, one is for staging laparoscopy. This is especially important for cancers like esophageal cancer, gastric cancer, pancreatic, liver, biliary tract, and colorectal cancers, and lymphoma. Diagnostic laparoscopy is also indicated for acute conditions, like in patients with acute abdomen, for example, equivocal acute abdomen, possible appendicitis, ICU patients, or even in trauma. Diagnostic laparoscopy is also used in chronic conditions like recurrent abdominal pain, chronic pelvic pain, liver disease, infertility, cryptorchidism, ascites of unknown origin. Others include suspected post-op complications and others. So other indications of diagnostic laparoscopy includes during a laparoscopic procedure, like for example, your laparoscopic cholecystectomy, that it is important to always perform a limited diagnostic laparoscopy before and after each procedure. For contraindications of diagnostic laparoscopy, absolute contraindications include inability to tolerate general anesthesia, basically the same with any laparoscopic procedure, uncorrected coagulopathy, limited expertise, and lack of proper equipment and instrumentation. Relative contraindications include general peritonitis, hemodynamic instability, especially in diagnostic laparoscopy and trauma, multiple previous surgeries, morbid obesity, and intestinal obstruction, and when there is ileus. For the preoperative care, I will not touch more on this because this has been discussed in previous lectures yesterday, including preoperative preparation. So basically, diagnostic laparoscopy has the same patient preparation and operative OR setup with the most laparoscopic procedures. So for the standard technique in terms of abdominal access, in patients who have no previous abdominal surgeries, our usual entry point would be the umbilical area, either with Hasson technique or Reveres technique, which was discussed yesterday. With previous midline incisions, we usually approach it via the Palmer's point, which is the most common. Others will approach it with left upper quadrant area, Hasson's technique, or optical with a 0-degree scope. From the illustration to your right, this is the usual trocar placement for a diagnostic laparoscopy. But you can insert or you can put more trocar ports as needed depending upon the target area, if it's lower abdomen or lower GI or an upper GI indication. So these are example of optical trocars, which was also discussed. I will just go through this, including the patient positioning and operative OR setup. So for limited exploratory diagnostic laparoscopy, this is usually performed routinely at the onset before any laparoscopic procedures. The main reason for this is that we need to determine if there are any trocar injuries during abdominal access entry, status of organs of interest, status of the size of the liver, stomach and bladder, if there is stomach and bladder distension, and if there's subsequent need for proper placement of other trocars. And this is also performed after or before the termination of the procedure to check if you left any like gauze or sutures, and then for if there are trocar bleeds after the procedure. So first things to do in limited exploratory diagnostic laparoscopy, especially for cholecystectomy, is that you perform a limited diagnostic lap. You assess the liver. You also assess the trocar sites and trocar placements, and you check for the following. After the procedure, you check for the trocar-induced entry injuries, other intra-abdominal pathologies, and the status of the gallbladder. So we usually approach this in a systematic approach. As said earlier, we need to check the entry point area of the if there are visceral injuries or any pathology. This is the onset where we insert the optical trocar or at the umbilical area. So we need always document the proof that there was due diligence done by the surgeons and no visceral injuries or other pathologies noted. And we should always be ready to do appropriate biopsies and fluid aspiration. Since we do diagnostic laparoscopy, all equipments must be on standby. For example, if you find liver pathology on a diagnostic laparoscopy, if the center has available a diagnostic ultrasound or laparoscopic ultrasound, it should be ready, and biopsy instruments and energy devices must also be on standby. If any significant pathology is seen, inform the family and discuss your plans first before any intervention. So for extended exploratory diagnostic laparoscopy, it has various terms. Some call it formal exploratory diagnostic laparoscopy, others standard diagnostic laparoscopy, or exploratory diagnostic laparoscopy. It requires additional laparoscopic skills and special instruments to prevent any visceral injuries during bowel reading or grasping of visceral organs. And it requires a proper functioning table where you can manipulate changes in positioning, like a Trendelenburg or reverse Trendelenburg position, and tilting left and sideways. So for the indications, it's indicated for when other diagnostic procedures have failed to establish the diagnosis. So it is used as a supplement or a complement to other imaging procedures. In such conditions like acute and chronic abdominal pain, trauma, cancer staging in ICU patients, or patients with ascites of unknown etiology. For the conduct of exploration, it is similar to limited diagnostic laparoscopy plus a more detailed exploration. We usually do it by quadrant, quadrant per quadrant. We usually start with the right upper quadrant and goes to the left upper quadrant, change position of the patient into a reverse Trendelenburg position to view the lower quadrant area. And there must be a complete bowel reading is performed where we do what they call a zigzag manipulation of the small bowel, where you start at some recommendations when you're doing it in the when the patient is in reverse Trendelenburg position, they usually start at the ileocecal valve going to the ligament of Treitz. So for the right upper quadrant area, the patient will be in a Fowler's position, on the right side up, and the surgeon's position at the left side of the patient. So organs that we examine here will be the right lobe of the liver, the diaphragm, subhepatic area, the gallbladder, part of the stomach, the duodenum, the hepatic flexure, transverse colon, and the falciform ligament. And then we move through to the left upper quadrant area, still in the same position, but this time we position the patient on the left side up. And the surgeon will be standing on the right side of the patient. So we check here for the falciform ligament, the stomach, the left lobe of the liver, the diaphragm, spleen, distal transverse colon, and part of the descending colon. Still in the left upper quadrant area, we also make sure that we will open the gastrohepatic ligament. This is it depends upon the indication of why you're doing the diagnostic laparoscopy. Additional areas that we examine would be the caudate lobe, the right crus of the diaphragm, the vena cava, posterior wall of the stomach, anterior surface of the pancreas, the gastric prelar, left gastric artery vein, and the lymph nodes, especially in the celiac and hepatic artery. Once we open the lesser sac, we also examine the gastrocolic omentum once we open it, and we examine the posterior wall of the stomach and the anterior surface of the pancreas. And then we change the position of the patient into a steep Trendelenburg position to examine first the right lower quadrant area. This time, the surgeon will stand on the left side of the patient. We examine the omentum, the transverse colon, and the cecum, appendix, ascending colon, and the hepatic flexure. Next is the left lower quadrant area. Still the patient in a Trendelenburg position, while the surgeon standing on the left side of the patient. On the right side of the patient here, the omentum and the transverse colon are pushed cephalad towards the left upper quadrant area, examining the descending colon, the sigmoid colon, and the rectum. For the pelvic area, where we last examined, usually the table is still in a neutral position, still in the Trendelenburg position. The omentum and the transverse colon are pushed cephalad, and the small bowel is pushed gently beyond the sacral promontory. Here, we examine the rectum, the bladder, the cul-de-sac, uterine ligaments, the uterus for the females, fallopian tubes, ovary, and the lateral pelvic walls. We have to identify landmarks in the pelvic area. We have the umbilical ligament, the median umbilical ligament, the ascis, the iliac vessels, vas deferens, and spermatic vessels for the males. Now, for the small bowel reading with multiple quadrants, the position is still in the Trendelenburg position. This is the most easiest way to do it, since the gravity will be pulling the small bowel towards the head part of the patient. Now, we usually start at the ileocecal valve all the way to the ligament of Treitz. Pointers that we need by doing this, we need always under direct visualization, meaning when we move our instruments, it should be under direct visualization through the scope. Use of non-locking atraumatic fenestrated bowel graspers. We do not pinch the bowel. We grasp the entire diameter of the bowel gently and grasp the mesentery gently. Camera operator has to keep view on the central always. Yeah, slow and gentle manipulation during lifting. And when there is resistance, you need to stop and assess the reason why there is resistance. And they said here that you do a zigzag manipulation of the bowel, going through like a book page. You see on the anterior part, and then you flip to see the other side of the bowel. Now, role for diagnostic laparoscopy for trauma is a well-accepted approach, especially in penetrating abdominal trauma. It can be used as a screening, diagnostic, and a therapeutic applications in trauma, in which one study or one paper, they said that about 55% of diagnostic trauma they did, they have a 55% success for a therapeutic intervention. So their recommendation is still the same, with a quadrant per quadrant diagnostic laparoscopy starting at the right upper quadrant area. So in the right diaphragm going to the liver, then going to the left diaphragm, the spleen, going to the stomach, and then to the pancreas, and then change position of the patient to examine the left lower quadrant areas, including the small bowel going to the pelvis. So I will present to you a short video presentation. This is a case of 60-year-old gentleman who has a diagnosed case of mid proximal to mid rectal carcinoma with possible metastasis already to the bone. So the indication for this patient in doing the laparoscopy is for this patient is for laparoscopic assisted diversion, transverse colostomy. So during the limited diagnostic laparoscopy, so we examine first the right upper quadrant area, examining the liver. So we have noted already that there is a possible lesion at the right lobe of the liver. Taking note of the peritoneum, the surface of the liver, and the falciform ligament. Then we go to the left upper quadrant area. We examine the surface of the left lobe of the liver. Since this is just a limited diagnostic laparoscopy, we don't have to take a look at the spleen, but at least we take a look at the peritoneum, at the subdiaphragmatic area. Then we scan going through the left lower quadrant area. At the same time, we are already documenting where are we going to put our ports for the procedure. So since this procedure is for laparoscopic assisted transverse colostomy, the initial port that we will place will be in the left hemiabdominal area. So we can use this to, if we need to obtain specimens or suction peritoneal fluid and assess the primary tumor location. So in this case, as you can see, it's all part of the rectum, the proximal rectum. It's already evident that the tumor involvement. And then you need to assess if there are involvement of the bladder. Examining at the right lower quadrant area. Just skip the part of the video here. Here we are examining the extent of the tumor involvement, whether there's involvement of the pelvic peritoneum or there are peritoneal seedings. Can also assess the involvement of there are involvements of or compression towards the ureters. Since this is a male patient, for female patients, we also assess if there's involvement of the uterus or other ovarian structures. Then for this case, after this, we proceeded to laparoscopic assisted transverse colostomy. So in summary, for limited diagnostic, laparoscopy must be performed before the onset and after the completion of every laparoscopic procedure to mitigate the risk of missing any unrecognized bleeding, visceral injuries, or pathology. For extended diagnostic, laparoscopy may be performed safely for proper indication, provided the surgeon is trained with adequate laparoscopic skills for proper handling of visceral organs with appropriate equipment and instruments and performing the procedure in a systematic manner. So laparoscopy should be a part of a surgeon's armamentarium in diagnostics, and diagnostic laparoscopy bridges the gap between imaging and definitive surgical decision making. Thank you.
Thank you very much, Dr. Parilla, for that clear and practical walkthrough of diagnostic laparoscopy. Next, we move on to the laparoscopic cholecystectomy, PALES 0BDI, a cornerstone of minimally invasive surgery, to be presented by Dr. Alembert Lee Ong. He had his subspecialty training in minimally invasive surgery, Singapore National University Hospital. He is a fellow of the Philippine Association of Laparoscopic and Endoscopic Surgeons, a fellow of the American College of Surgeons, and a member of Endoscopic and Laparoscopic Surgeons of Asia. Let us all welcome Dr. Lee Ong.
Thank you. Okay. Uh, Thank you. Thank you for the kind introduction, and also thank you to the organizers of this workshop, especially to Dr. Henry Chua, and also to the ELSA outreach program on this workshop in in laparoscopic surgical skills and advanced suturing. So the topic of my talk is on laparoscopic cholecystectomy and also on the PALES Zero BDI campaign. So for disclaimer, the informations are widely available on both the laparoscopic cholecystectomy. I will be using the Zero BDI campaign materials from PALES. I will also be talking about some of my experience and also an opinion on laparoscopic cholecystectomy. I do not claim to be an expert. Similar to you, I'm also continually learning from not only from experts but also from interaction with new people going into minimally invasive surgery. So my talk now would be mainly focusing on elective uncomplicated gallbladder stones. I'll also need to thank Dr. John Paulo Chua, whose lecture he kindly shared and which my talk today is based on. So my talk will contain some information about lap chole and the bile duct injury. I will point out the safety landmarks in laparoscopic cholecystectomy emphasized by the PALES Zero BDI. Also talk on the Strasbourg critical view of safety. Enumerate the steps in laparoscopic cholecystectomy. Talk about the PALES Zero BDI timeout, and also show you a clip of one of my laparoscopic cholecystectomy. So with respect to laparoscopic cholecystectomy, this is currently one, or if not the most common surgical procedures being done. Probably In my main hospital, it's probably around 85% of MIS procedures and probably around 65% of all GS surgical procedures being done. It is currently the recognized gold standard in dealing with symptomatic gallbladder stone. With respect to BDI, this is the most catastrophic complication that you can encounter when doing a laparoscopic cholecystectomy. It is both devastating to the patient as it will entail recurrent morbidity and possible decrease in life expectancy of the patient. It is also devastating to the surgeon as this will uh, make a big hit on the surgeon's confidence as well as probably professional life and finances if this case do ever go to court. So the incidence of BDI is laparoscopic cholecystectomy. BDI is around 0.4 to 0.8% from literature. This is allegedly twice the rate in open cholecystectomy. So there are risks that increase your chance of encountering BDI. This can be grouped as to patient factors, local factors, surgeon factors, and technical factors. So but BDI does not mean that this is the problem seen only in novice surgeons, but this can also happen in the hands of experienced and competent surgeons. A Swedish study indicated that the most likely chance of encountering BDI is actually during one's 25th to 100th laparoscopic cholecystectomy. So I think the reason for this is mainly we become complacent when we talk about simple gallbladder, and this will definitely increase your chance of encountering disaster. So what is important is to approach laparoscopic cholecystectomy as a difficult procedure, no matter what the situation. Keeping in mind the risk for the risk for injury and complication, and only rest when you are sure that you have safely and successfully performed laparoscopic cholecystectomy. So, based on study, the cause of BDI is most of the time is due to visual misperception. So it accounts for 97%, with only 3% being really technical faults. So how do we manage or try to avoid this visual misperception? We can use the best equipment available, use an angled scope to give you a better view, always keep the operative site clear, constantly reorient yourself. This is usually, it really boils down to what the surgeon prefers. Some would prefer a very close-in, zoom-in view while doing this surgery. And this can cause some disorientation. So it's once in a while, it's best that you zoom out and try to look at the whole forest and determine where you are in it. Then, if things are really difficult, you can also use enhanced imaging, such as the use of ICG. So, with respect to steps in cholecystectomy, port placement would be the usual start. So there are a lot of port placement being used for laparoscopic cholecystectomy, from 4, 3-port to single port. And there's also more exotic placement, such as at the bikini line, just to hide the scars. So, but for me, I would suggest that you start with the 4-port. And why do I suggest 4-port? So, these are because the other port placement actually adds hindrance to how you do your surgery. And with already the inherent risk for BDI, no matter what, why add additional hindrances to your technique? But this does not mean that um, you should avoid pushing the boundaries, because only when in pushing the boundaries do we innovate. But as I understand from talking to colleagues here, the more common port placement here is the 3-port, and that is good. Um, so you can go into the 3-port as long as you have someone there who is an expert or competent in doing the other port placement, so they can guide you. But if you don't have anyone beside you and you're just starting, I would advise or suggest you do the 4-port first and progress from there. So steps after placing the ports, you should initiate a careful and proper insufflation. Start low and slow, low pressure, low flow rate. And once you have achieved the target pressure, you can then increase your flow rate to match what if you are using a suction instrument. So after which we advise a cursory examination of the abdominal cavity. This is mainly to assess for presence of any access injuries, any bleedings that may have uh, be incurred during your access, and also to note any gross abnormality. So after which the succeeding steps are actually not in succession, but they can be done concurrently in relatively different orders. Okay, so with respect to positioning of the gallbladder, in the 4-port technique, we advise that the fundus be held and directed towards the right shoulder, and the Hartmann or the gallbladder cystic junction be retracted inferolaterally. So, what are the landmarks in laparoscopic cholecystectomy that would more or less keep you safe? So, the Rouvier sulcus, the R4U line, which is the line imaginary line trace from the Rouvier sulcus towards the umbilical fissure or the falciform ligament. So anything above it is uh, relatively safe to do dissection on, and anything below it should, as much as possible, you keep a high level of caution. So you also identify the gallbladder cystic duct junction, the CBD, and also the duodenum. So the most important actually when you do the identification of landmarks is you want to identify the gallbladder cystic junction. This is the key to avoiding um, the major duct and also where you would like to initiate your surgery. The next would be to open the peritoneum. I believe this is the most important step to starting your dissection because the peritoneal covering holds down the lower half of the gallbladder with the other main ducts. So if you open up that peritoneal covering, which is quite tough, You will have access to the loose fat and the loose areolar tissue underneath. And during the course of your dissection, you will note that you will be able to lift the lower segment of your gallbladder and move it away from the major ducts. So as you can see in the upper picture, with the peritoneum still intact, it's quite close to your CBD. And once you have opened it up and start dissecting, you'll notice that it starts to move away from your CBD. So dissection is best done millimeter by millimeter. Keep close to the gallbladder. You have a variety of options on how to deal with this loose areolar tissue. So you can use the cautery, you can use the Maryland, you can use the suction instrument. So during the dissection, I would advise you do the flag waving maneuver. So you would be able to dissect from both sides and also use it as a means to see if there are any structures in the way of your dissection. So what you can do is if you are if you're dissecting from the anterior going to the back, you put the tip of your dissector into the space where you intend to go through, then flip the gallbladder uh, to the other direction to see in the posterior where your tip is. Because of the loose tissue there, you would usually be able to make out the tip of your instrument. And if there are other structures there, try to avoid going through it, then reposition and until you only see the tip of your instruments, then you can go through that particular thin layer. So what is the Strasbourg critical view of safety? There are three critical criterias. So you need to clear the hepatocystic triangle of fat and fibrous tissue. The lower segment of the gallbladder should be off the liver bed. So you should be able to see the cystic plate. And when you look at the gallbladder, you have only two structures going in, which should be the cystic duct and the cystic artery. So once you have achieved the critical view of safety, this is where the PALIS 0 BDI timeout comes in. So PALIS suggests that you call for a timeout. So the surgeon indicates that he's ready to clip. So what is the timeout for? So actually, it is like a mental refresh. If you encounter some problem with your phone, either it go running slow or encountering trouble, we do a hard reset, diba? That clear because if you go straight, chances you will go continuously, even if you encounter that, there's a high chance that you'll get an error. So by doing this pause, you sort of do a mental refresh. So whatever perception that you have, momentarily you'd like to erase whatever perception you have and try to identify all the landmarks, reorient yourself with the structures, so you get a clear view or a fresh view of what you are dealing with. So this is also to counter check your perception. So you need, what is indicated here is you need to ask the surgical team if they agree with what you are seeing. And that would, these two breaks in the flow of your surgery will more or less hopefully counter the visual misperception that may have developed as you do the procedure and make your surgery safer. So this is also something that you can put in your or operative technique, and that would also be evidence that you have done additional steps to ensure the safety of your patient. So after which you cut and clip your cystic artery and duct, dissect the gallbladder off the bed, extract the gallbladder. I would suggest you do extraction with a specimen bag. This may be a condom, but I prefer a improvised extraction bag from a sterile cuff of a glove. So after which you recheck the area for bile leaks, bleedings, and security of your clips. Then afterwards, removal of the ports under direct vision. So this is a video of one of my procedure. So I initially insert the epigastric port, check on the gallbladder, see if there are anything I need to address before putting in additional ports. Since none, I ask the assist to put in a second at the lateral. Then I now check where I will be starting my surgery. And this will be the point where would tell me where I should insert my second working port. Since the junction is below the R4U line, I decided to start above it. So this is for me, the most important part is to open the peritoneum. Go as high up as you can. Both in the posterior and also in the anterior. Since in this case there's a vessel there, I decided to skip that area and to open up the anterior covering. You will notice that as I cut the peritoneal covering, there's there's a give to your lower part of the gallbladder. It's distances itself from where your CBD is. Then once it's open, I start the dissection of the hepatocystic triangle. Note I'm also doing the flag maneuver. In this case, it seems that this is the Hartmann's. At this point, I decided that it's as far as I can go with the scissors. I started to use the suction instrument to do blunt dissection, to macerate the fat, and also suction out any things that I can suction, take out with the suction. Then I think I shifted to the Maryland. I can now see the common hepatic behind. So relatively, I'm sure I'm safe. I'm trying to open up further the hepatocystic triangle. keeping the area clean. Um, I think I was planning on, yeah, trying on releasing the lower segment of the gallbladder. So I decided that it's a bit tough. So I decide to separate the two structures, the vessel and also the cystic duct. There's some oozing behind, so I decided to clean it out and try to assess why there was oozing. I think I assessed that though there was oozing, it wasn't that much. Repointing to the common hepatic, I believe I decided that I can now clip the vessel, which I think it was the cystic artery. At this point in time, I am actually satisfied I've already achieved enough of the critical view of safety. Noted the reason for the tortuousness and being tracked down by a fibrous tissue, which I cut, you know, extension of the cystic duct, moving further away from your main ducts. I decided to deal with the oozers. Then I believe I clipped the cystic duct. So try to go as close to the junction as possible. When you're clipping, slightly relax the traction on your left hand as to not tent up your junction. So after cutting, dissect the gallbladder off the liver bed. I noted that the anterior peritoneal covering is not totally open yet, so I proceed to extend it. That would facilitate dissecting off the gallbladder from the liver bed. Eventually completing the dissection of the gallbladder of the liver bed. After this point, I would put down the gallbladder, re-examine the area for any bleeding or significant oozers, try to control them before going to extraction of the gallbladder so as not to encounter significant bleeding during the course of extraction. Then I inserted my improvised extraction bag. Okay. Proceeded with extraction to the camera port, incision actually. So rechecking the area of surgery or dissection, making sure that there's no renewed bleeding, uh, taking out any blood pools, checking for bile leaks, bleedings, taking care of what I assume to be oozers, checking also the clips. I would eventually remove the ports under direct vision to check for any bleeding from the port site, and subsequently desufflate and end the procedure. Okay. Okay, thank you. Any questions? Okay. Thank you.
Thank you, Dr. Leong, for highlighting the importance of safety and precision in laparoscopic cholecystectomy. Our third masterclass presentation is on laparoscopic appendectomy, to be presented by Dr. Russell Adrian Obenza. He had his subspecialty training in advanced minimally invasive surgery at Cebu Doctors University Hospital and general surgery training at Vicente Soto Memorial Medical Center. He is a member of the Philippine Hernia Society. Let us all welcome once again Dr. Obenza.
Thank you for that introduction. I'd like to say thank you first to our organizing committee, the sponsors, and also to our course director, Dr. Henry Chua. So I will be discussing today on doing safe laparoscopic appendectomy. So I will be showing you a step-by-step step-by-step on how this is done through videos. So by recommendation, this is the scoring system of PALES for the videos that you will be submitting. So we have one for cholecystectomy. This one is for laparoscopic appendectomy. Okay, so we will be going through this one by one. So to begin with, the step one is abdominal access and insufflation. So this has already been shown by the previous speakers. So I will just skip directly to step two, which is the diagnostic laparoscopy. Okay, so upon entry and visualization of the abdomen, the first thing to check is the abdominal entry site. We check for any injuries or bleeding. Then we check all quadrants of the abdomen in a systematic manner, usually in a clockwise fashion, seeing if there are other pathologies. Then we go back around, again, carefully checking all quadrants of the abdomen. So important to check is the status of the appendix, whether it is ruptured or not, because it gives the surgeon an option whether he is comfortable to proceed with doing the appendectomy laparoscopically or not. Okay, so next is step three is secondary trocar insertion. So there should always be direct visualization of all trocar placement to avoid inadvertent hollow viscous injuries. So take note at the manner by which a trocar is inserted. It should be in a controlled twisting motion. And we can use a lap instrument in providing counter traction when inserting a trocar to provide additional safety. So these are the various variations in trocar placement, but most commonly we usually use the standard 3 ports. So the fourth step is positioning of the patient. So the patient should be tilted right side up, slightly Trendelenburg position. And the urinary bladder should be empty with or without a Foley catheter. So we can see here the actual operating room setup with the surgeon and the assistants at the left side of the patient and the monitor on the patient's right side. Okay. So step 5 is suction, and irrigation. So there should be immediate evacuation of suppuration and fecaloid material. So it is a process that we call decontamination. Very important. Initial step in laparoscopic appendectomy is a process of lavage and aspiration of purulent fluid. Now, there are different schools of thought with regards to lavage, but in our practice, we must be careful to aspirate fluid first before we do irrigation. So always aspirate all the suppuration first before we irrigate. So until all the visible contaminants have been aspirated. So the European guidelines recommend 6 to 8 liters of lavage and aspiration to minimize intra-abdominal abscess rates in complicated appendicitis. And for Asians, it's 4 to 5 liters due to the smaller body habitus. Step 6 is the identification and mobilization of the appendix. Now, what we would like to see here is the proper instrumentation and handling. So in some cases, even the suction tip alone or a blunt instrument, bowels already move away from the operative field with proper positioning. So it's recommended to use blunt instruments or atraumatic graspers, and there's a no-touch approach of the appendix. Meaning we manipulate the appendix indirectly by handling the surrounding tissues such as the mesoappendix or the ileocecal fat pad. And sometimes mobilization of the cecum would be necessary in some cases for better visualization. Next is step 7 is the exposure of landmarks. So in appendectomy, all landmarks should be identified. The cecum, the taenia coli, the ileocolic junction, the terminal ileum, and the appendiceal base and artery. Now, what we want to see here is that the surgeon would actively demonstrate with a blunt instrument the important anatomic landmarks necessary before initiating dissection. So these landmarks are particularly helpful in identifying and locating the appendiceal base, especially in difficult and more complicated appendectomies. So again, the ileocolic junction, the terminal ileum and appendiceal base and artery. Okay, now we proceed to step 8 of 12. This is serial ligation of the mesoappendix. So there should be a traumatic retraction of the appendix, proper angulation and position. We use an advanced energy device close as in parallel to the appendix. So visualized here is the appendiceal artery ligated by the advanced energy device. So it is also good practice, as you see here, to check from time to time the back of the appendix to make sure that no other structure is being grasped by your energy device. So we visualize that the base is already at the confluence of the taenia coli, and now we are ready for base ligation. So this is what we term as the critical view of the appendix. So we can see the taenia coli, the base, and ideally we see the appendiceal fat pad is already free, and also we can view the terminal ileum. Okay, so take note that there are also other advanced energy devices available, and the surgeon should be proficient in using these devices. So moreover, we can still use the monopolar cautery, then serially ligating the mesoappendix or by using clips or even ties. So step 9 is the appendiceal artery and stump ligation. So it can be ligated appropriately depending on the condition of the base, and of course the assessment and discretion of the surgeon. So here we use a intracorporeal knot tying using a free tie and a multi-filament absorbable suture. So this requires certain skill and technique that can be done as long as the surgeon is comfortable and adept in doing this. But more important is the secured closure of the appendiceal base, and needless to say, without significant injury to the adjacent bowels and cecum. Okay, so there are also other options for appendiceal stump closure. Aside from the intracorporeal knot, we have suture ligation. We can anchor the base, or we can bury it by suturing. There's also extracorporeal knot using endoloop, use of endostapler or laparoscopic stapler, and the use of even plastic or metallic clips. However, available papers would suggest that there is no significant difference in the overall complications and comparing these different methods of stump ligation. So that's suture ligation, endostapler, extracorporeal knot, and clips, so whichever is available in our different institutions. So step 10 is specimen extraction. So the specimen is extracted directly into the trocar site with a chloride extractor if available, provided that we can ensure there's no contamination of the surgical field and the trocar site. Okay, so otherwise, it's still ideal to recommend the use of a specimen bag for extraction, be it a condom bag, modified hand gloves, commercially available endo pouch or endo bag for the extraction. So the procedure does not end with the extraction of the specimen. So we have to reevaluate the operative site and check again the integrity of the artery and stump ligation. So we can do a limited bowel run to check for injuries, bleeding, residual suppurative and fecal material, as well as any interloop abscesses. So at this point, we can also suction out residual lavage fluid prior to the termination of the procedure. So again, lastly is closure. So all the trocars are removed under direct visualization. The intraperitoneal carbon dioxide is evacuated prior to the removal of the Hasson trocar. And closure of the umbilicus is done under direct visualization. Okay, so that would be the last step. Thank you for your kind attention and good morning.
Thank you so much, Dr. Obenza, for that very comprehensive discussion. Next, we proceed to the laparoscopic inguinal hernia repair, a common yet highly technical procedure to be presented by Dr. Hao Piao Lo. Dr. Hao Piao Lo is a general surgeon in Hospital Raha Permaisuri, Bainan, Ipoh. He is a life member of Academy of Medicine, Malaysia, a life member of Society Endoscopic and Laparoscopic Surgeon, Malaysia, SELSMA. He is a life member of Malaysia Hernia Society. Once again, let us all welcome Dr. Lo.
Can I actually maximize this? Can I actually maximize this? No. Bigger. Bigger. Is it possible? Because it's a bit too small. Or this one, this slideshow. Yeah. No, it's okay. I think it's all right. Okay, better. Hi, good morning. I'm Dr. Loh. So again, thank you, Dr. Henry, and also Prof. Lamanto for inviting me for giving this video masterclass regarding lap inguinal hernia repair. So for this video presentation, mostly I didn't put up video because a lot of times I will find out that I will always keep on skipping. All right. So my presentation basically is about picture clips, and then I will show you step by step how it's going to be done and give you an overview. First of all, before I start, may I know how many of you have already seen before inguinal hernia, laparoscopic inguinal hernia repair? None? Yes? Just show of hand so that roughly I know. All right, good. So probably this will be a run through and give you a bit more idea actually what is actually happening. Because during my practice, I actually take me 1.5 years to understand what is happening because my boss who doing the surgery does not actually talk anything. He just do it quietly and then I just need to think of myself. All right. So hopefully this procedure, after I run through with you, you have an idea actually what is laparoscopic inguinal hernia repair. So again, all images and references to the instrument brands presented in this lecture are educational purposes and carry no advertising or promotional intent. So this is my outline. What is the preparation? What are the equipments? What is the position? And what is the procedure? Which is I will go through TEP and TAPP and what is the advantages and disadvantages of TEP versus TAPP. So preparation. So first of all, you need to take the consent. That is the consent form available in my hospital, in Malaysia. So we explain how the procedure is done, disclose probable complication during operation and post-operation, and also explain regarding the post-op care. Next, you need to prepare antibiotics. Okay, in Malaysia, the Ministry of Health already fixed that to use IV cefazolin 2 grams stat as a pre-op antibiotics. Next is to decide what are the meshes that you're going to use. It can be a polypropylene or polyester. It can be a anatomical mesh or flat mesh, and the standard, the smallest size you use is 10 times 15. Nothing smaller than that. Next, equipment. These are the equipments that is going to use during the laparoscopic inguinal hernia procedure. I have the S-curve retractor. These are the bowel grasper, Maryland grasper, scissors. This is actually rod and introducers, 30-degree telescope, 0-degree telescope, and then light cable, monopolar cables, insufflator tubing, camera heads, and the 5mm and 11mm trocar ports. Both for the procedure, whether you're doing TEP or TAPP, are using the same instrument as well. And bear in mind that the instrument tip that we use usually are preferably a smaller and shorter one, because it's a very small confined place that we are going to do the surgery. Next, of course, you need the laparoscopy tower together with this monopolar or bipolar diatomy machine. So position, how are we going to position the patient? So this is how the setting going to be. So there's the patient where we put it supine, and then there's the patient head. There's me, the surgeon. There's my assistant. There's my nurse. And then there is the anesthetist. And how about the instrument position? The laparoscopic tower will be over the leg, followed by the diatomy machine. Lap bias will be straight out, putting over the leg. And then there's the nurse instrument trolley. And that's the GA machine. So basically, this is all how the positions of the things going to be done. It is also the same for TEP or TAPP. Next, the procedure. So what is TEP? What is TAPP? TEP means it's a total extraperitoneal repair, where TAPP means transabdominal preperitoneal repair. So what is the concept? Hopefully this diagram can clear your doubts. What is it? TEP, you can see that you go into the preperitoneal space, which is the peritoneum above. Where TAPP, you will go into the abdominal cavity, cut open the peritoneal layer and repair through over that space. So first, let's go through the TEP first. First, you place the patient in the supine position, and we have marked the hernia, which is over the left side. That is the symphysis pubis. That is the anterior superior iliac spine. That is the midline. So the 10mm camera port will be placed slightly to the left side, 5mm at the middle, 5mm another one at the middle as well. where we divide it into 3 portions. So why the 10 mm camera is slightly over to the, away from the midline is because you want to cut through the anterior rectus sheath, spread the rectus muscle, and goes into the posterior rectus sheath. So first, use a blade, cut. Then after that, you use your retractors and also your R3 spread through the subcutaneous fat and also the muscle until you see the anterior rectus sheath. Make a cut at the anterior rectus sheath and then you see the muscle and you spread the muscle laterally. Then you put in the trocar, all right? Then that is the first thing you're going to see. So this is how, because usually most of the time, if you look at the video, they are going to show you what is going to see inside. But how are things happening outside? Actually, not much people will show. This is what is going to happen outside, all right? The ports will be like that, camera in that position, and then it goes into the extraperitoneal space. That's the first thing you're going to see. And then once you know that you are in the correct plane, which is the muscle on top, the rectus, the posterior rectus sheath below, and that is just the fascia at the middle, then you can start inflate your air. We usually start at low flow, subsequently follow into the medium flow, which is around 12. So over here, we will use a 0-degree camera, and this is how it's going to look. How is the dissection going to be done? It will be done, that is the first dissection area you are going to do, which you dissect all the way on the medial part, and it's all the way to downwards. You use your camera, your telescope to actually dissect it, which is a blunt dissection using the 0-degree. You dissect all the way down until you have seen the symphysis pubis. Okay? Next thing, you're going to insert the working part. Working part, sometimes if you just gauge from outside, if let's say the patient is fat, sometimes you might miss the place or you place the pot wrongly. So I always say it's best to just take a needle, insert it, and roughly you gauge and know whether you are in the correct space that you want or not. This is very important, all right? A lot of failures and things start from the pot placement. If you're able to place the pot properly, then you get a proper space and place in your instrument properly, and you'll be able to finish your surgery. This is the first pot placement. You put in a pot. That's what is going to happen outside. Next, you put in a second needle. Okay? And then after that, you put in the second pot. All right? And next, you dissect or put in your instrument and dissect all the medial until you have seen the radial space. Okay? Meticulous dissection of the central area and to see the radial space. Next, you move your camera. You can change your camera to a 30-degree and then look it slightly to the other side. What are you seeing here? This is actually the sac. And you go in through above there, go into the space of Bogros, where you dissect it and you open it up. Okay, whatever I show at the middle, that is the sac. You spread it open. And that is what you're going to get. Again, your sac will fall into the medial. And then you try to separate the sac downwards. And this is usually the end of probably after you dissect all the sac and everything and separate out the cords and also the structures. So usually you probably will see this by the end of almost the end of the surgery, right? So let us just label through what are you actually looking at. This is a bus. This is the testicular vessels. This is actually the deep inguinal ring. This is the symphysis pubis. Here, down there, there's a peritoneal line. There's the iliopubic tract. This is a triangle of doom. And this is a triangle of pain. All right? So usually I mean, your prof or your consultants will actually dissect until here. So you must be able to identify all these structures, because eventually when you start to do this surgery, you must be able to identify all the structures that I've shown you right now. Next, you roll the mesh, push it in, then you cut the suture, unroll the mesh, and bear in mind, you will try to put the mesh 2 cm below the symphysis pubis and tuck along the peritoneum fold line. Make sure the mesh is open properly and laid flat and not folded. All right, so next we proceed to TAPP. Right, this one have a right side inguinal hernia, the left side done open, there's no recurrence. So this is where all the markings that we did. So this imaginary line. So the middle one is actually the camera port, where and then and then the two sides one is actually the working parts. So usually we'll put one hand breadth away from it, and it's 2 cm, roughly 2 cm above and below. This is a 10 mm camera part, where this is a 5 mm working part. Clean and drape the patient. You can inject LA, then followed by incision. Open it up, just like the normal method of you do, open method of inserting the parts. So you put in the pot, all right? Inflate the abdomen, put in the telescope. This is what you're going to see, all right? This is what are you going to see. So again, let's label what you are actually seeing. This is the medial umbilical ligament. This is the medial umbilical fold. This is the lateral umbilical fold. This is the deep inguinal ring. This is the vas. This is testicular vessels. Symphysis pubis. This is a urinary bladder. All right. So once you put in, you don't just able to identify where is the inguinal only. You must be able to identify all these structures clearly. All right. Next, you put in the working parts. All right. You can inflate, you can inject the local anesthesia for better pain control after the operation. Make an incision, put in the pots. All right, first pot in, followed by the second pot. This is how it's going to look like before the surgery starts. All right. And next, this is how the surgeon and the laparoscopist is going to be standing. Okay, for TAPP. All right, so first, the surgeon will usually put in the scissors, and then there's going to burn a bit on the peritoneum to make markings. They use either using hooks or scissors. Actually, it's to delineate where the line you're going to cut. So you tend the peritoneum down and make a cut and open it. The first space, this is the lateral dissection, where you're going to open up the space of Bogros. Then you move on to the medial side to open the space of Retzius. So when you open until this area, please note that this is your inferior epigastric artery. Okay, it's very important you keep the inferior epigastric artery upwards, because if it falls down, it's very, very difficult for you to do the rest of the section. Next, you keep on cutting, spread to the medial side, and here you try to dissect into the radial space. What are you going to find? Actually, you're going to look for your symphysis pubis. All right, so dissect laterally, go medially, and then go and find your symphysis pubis. Next thing, stretch the hernia sac, and you use your Maryland to dissect it until you can see the vas deferens and also the testicular vessels. Continue to spread all the adhesions and all the fibers upwards until and then if let's say that whenever you are dissecting and you are feel in doubt whether which plane are you going properly or not, what you do is actually you can lift up the peritoneal fold and see what are the structures below. Once you're happy about it, then you can leave it back down again and use the Maryland, continue to separate the cord structures from the sac. Separate the, this is what we do, okay? We separate it. So what are you seeing now? That is a sac, that is the testicular vessels, and this is the vas deferens. So this sac is slightly big, so this surgeon decided to actually tie off the sac. So they put the suture behind the sac, pass the suture behind the sac, and then they make a knot. Tie off the knot, then after that, they use the scissors and burn and cut the sac. So that is a proximal sac. If you lift the peritoneal fold back up, this is how it's going to look like below. Okay, that's the advantage of doing TAPP, where you can see up and down, inside and outside if you are in doubt. But in TEP, you can only see the extra peritoneal space, but not the intraperitoneal space. Next, you separate the rest of the peritoneum as low as possible. That is actually the peritoneal line. You will spread it all the way down. And in the end, this will be the last view that you're going to see before you put in the mesh. This is the peritoneal line. Okay, so the rest, I think the structures, I don't think I labeled here, but hopefully you can know, you can see in this picture, where's the symphysis pubis, where's the radial space, where is the bladder, where is the testicular vessels, where is the vas, all right? You must be able, and where is the triangle of doom, triangle of pain, and where is the inguinal orifice. You should be able to identify it, okay? Next, roll the mesh. Usually we'll tie it and make a knot. Then you push it through the 10 mm pot. Use push all the way in, sorry. And then you will put the mesh in, and once you put in your telescope, that's what you're going to see. Again, place the mesh properly. And here you try to find where is the, you make sure that the mesh is cross the midline and 2 cm below the symphysis. And find where's the lacunar ligament, and you put the tacker on top of it. Right? So that it don't move around. Next, cut off the suture and unroll the mesh. Sorry. And unroll the mesh. Make sure the mesh is laid open and unfold nicely. For TAPP, you need to suture back the peritoneum. Suture from lateral to medial or medial to lateral. Either way, in the end, you must make sure that the peritoneum is being sutured back. So what are the advantages and disadvantages between TEP and TAPP? So for TEP, slower learning curve because you are at an unfamiliar space. TAPP is faster because it's an intraperitoneal cavity where everyone familiar with the space. And for TEP, for TAPP is suitable for irreducible, obstructed, or even an inguinal scrotal hernia. But for TEP, unless you are in a very, very skilled hand, probably is not suitable for irreducible, obstructed, or inguinal scrotal hernia. You can do diagnostic lab or examination of the contralateral, whether there's hernia or not in TAPP, but it's a bit difficult for TEP. And however, for doing TAPP, sometimes you might need to deal with intra-abdominal adhesions. Working space for TEP is definitely very, very small, and TAPP is definitely relatively bigger. So conclusion, laparoscopic TEP have a longer learning curve because of different view and also a smaller dissection space. Conversion of TEP and TAPP to open is not a failure. Please remember that it is not a failure. I converted probably 20 to 30 when I start off that time. Because why? Always remember this, safe surgery and properly repair of hernia always come first. You don't want the patient to have recurrence. Recurrence repair can be very difficult and it can be disaster. All right, and understanding anatomy is an essential and core basics of lap hernia surgery. And patience is the key of success. All right, thank you very much.
Thank you, Dr. Law, for that excellent and insightful presentation. And finally, rounding out this morning's video masterclass is the laparoscopic ventral hernia repair, to be presented by Dr. Don Edward Roselio. He had his subspecialty training in surgical endoscopy and upper gastrointestinal surgery at Prince of Wales Hospital, Chinese University of Hong Kong. He is the board of director of the Philippine Association of Laparoscopic and Endoscopic Surgeons Examiner, Philippine Board of Surgery. He is the vice chairman of the Department of Surgery in Cebu Doctors University Hospital. Once again, let us welcome Dr. Roselio.
Thank you for the kind introduction. I would first like to thank the organizers for inviting me here today to speak in front of you. To the organizers, to the sponsors, and to the attendees, thank you. So I'll try to talk to you about ventral hernia repair. So first of all, when we talk about ventral hernia repair, what should we put into mind is safety. So when we talk about safety, we have to define safe. So it is protected from or not being exposed to danger or risk or not likely to be harmed or lost. So there are synonyms that you could see. The last one says unadventurous. So it appears prudent to recommend that less experienced surgeon should start with less complex cases. So that's one thing, that's the driving thing that we want to talk about. So as we can see in the illustration on the right, there are several types of ventral hernias. It can be, some of them are midline, like an epigastric or an umbilical hernia, but some of them can be lateral. And of course, the inguinal hernias have been talked about earlier. So the diagnosis of ventral hernias can be done by physical examination. However, physical examination as of this day and age is a bridge. Ideally, imaging modality should be done. Diagnosis can be a challenge for patients with previous surgery, obesity, incarceration, or those with small defects, especially those at uncommon sites like the flank, the xiphoid, and the suprapubic area. Ultrasound has the advantage of being dynamic, meaning the ultrasonologist can ask the patient to strain and you could see the contents go through the defect. However, CT scan remains the most informative. It has a 98% sensitivity and an 88% specificity. CT scan is helpful in defining non-midline hernias, the relationship of the hernias to surrounding structures, defining the integrity and the structure of surrounding muscles, and in deciding on the safest point of access on where and how to anchor the mesh. CT scan, though, cannot determine the presence and character of intra-abdominal adhesions. MRI can also be useful in certain cases, but generally it is CT scan. So when we talk about safe laparoscopic ventral hernia repair, what's important is careful planning, precise execution. That's very important, and attention to detail. So these are the three things that you need to think about. There are several steps, but the preoperative consideration includes patient preparation and selection. So preoperative considerations decrease the factors which may lead to recurrence, factors which increase intra-abdominal pressure, like enlargement of the prostate, constipation, ascites, obesity, and COPD. So these are the things that you have to consider. So if the patient has an enlarged prostate, maybe you want to have that repaired first, or patient starts on medications prior to the hernia repair. Preoperative consideration. We talk about how to approach the patient. Do you plan to approach this patient laparoscopically or open? You have to anticipate the complexity of the surgery, considering previous hernia repair, the presence of a mesh, whether it was done anteriorly or was the previous surgery done posteriorly, the size of the defect. So generally, based on the recommendations of the International Endo Hernia Society, the use of mesh is necessary for all abdominal wall hernia defects, independent of the defect size. Ayoy. Sorry. I'll charge you. Sorry.
Currently, we're experiencing some technical difficulties. And we still have some refreshments to the side if
Sorry
you'd
about
like.
that. Yeah. Dili na po iba diri. Dili ko lobat.
Sir.
Yeah, I think na siya nakitaan nga na ay nakita kuan tingali kung tayo nakita nga
Pwede na-replay na balik lang.
yeah.
Oh, so soft and so clear.
While we navigate through
No,
the
it's okay.
technical
I don't have low battery. So I think it sends some virus. Needs a mask. Sorry. So we go back to where we were. Seeing the same thing I'm seeing. Okay. So other considerations. So as I mentioned, the generally accepted size for hernia for laparoscopic repair is about 10 centimeters, although most experts have set the limit to about 15 centimeters. So other things that you need to consider aside from the size of the defect is the location of the hernia, whether it's in the flank, midline, incarceration, obesity, fistula, ascites, the resources available, what's available in your locality, and the experience of the training and the training of the surgeon. So resources includes people that you could call for difficult or unexpected problems. So previous hernia repair is one of the factors which significantly increases operative time, requiring adhesiolysis, and the other factor is the surgeon's experience. Other preoperative considerations include the loss of domain. It is defined as massive hernias containing greater than 30% of the abdominal contents, that when those contents are reduced, it will cause major abdominal hypertension, leading to what we call as an abdominal compartment syndrome. Other considerations are previous abdominal skin grafts, wherein adhesiolysis may cause graft ischemia or necrosis. So large prosthetic meshes, which needs to be removed. These are considerations: incarcerated hernias, active or subcutaneous fistula, which is considered as a contraindication for putting a mesh because of the risk of infection, missing abdominal muscle or fascia, wherein what's required is already a component separation technique. And consider bowel preparation. The biggest advantage to bowel preparation is to increase the working space. Intraoperative considerations include the anesthesia, prophylactic antibiotics. So based on the recommendation of the Infectious Disease Society of America, they suggest at least single dose IV cephalosporin. The use of urinary bladder catheter, it's necessary for hernias wherein it's lower down near the xipho, symphysis pubis. However, if it's near the xiphoid, then probably it's not necessary unless you expect a prolonged procedure. Patient positioning is considered intraoperatively. Plastic drapes. Plastic drapes, there was a retrospective review involving about 500 6 lap and open ventral hernia repairs, and a separate meta-analysis which was published in 2007, and it was revealed that there was actually no evidence that plastic drapes actually reduced the incidence of surgical site infection. With regards to abdominal access, it should primarily be based on the surgeon's experience, outcomes, and the technique, and take into consideration the patient's history and anatomy. So whether you use or prefer to use a Veress needle, optical trocar, open technique, it depends on the patient's training and experience. Port placement, what is ideal should be direct visualization and as lateral from the mesh as possible. So other interpretive consideration includes adhesion lysis, which should be done in a meticulous manner. Measurement of the hernia defect. We'll try to talk about this one. So measurement of the hernial defect can be done internally or externally. It can actually be seen on the imaging studies, more specifically by the CT scan or the ultrasound, so they can actually measure the defect. And with regards to the measuring of the defect, it's important because so you can prepare for the size of the mesh that you're going to use. So ideally, in the past, they would say that you need an overlap, minimum of an overlap of about 3 centimeters, and an ideal of about 5 centimeters. However, there have been studies and depends on the defect or the size of the defects. So the larger defect needs bigger overlap, smaller defect, less overlap. There have been studies and papers regarding the defect to mesh ratio, and you will be able to see that it was 14:1 and 15:1. So if you think about it, we'll talk about actual cases and numbers. So if you have a defect which is about 4 by 5 centimeters, so it's 4 by 5, imagine a 4 by 5, it's a rectangular. And if you want to use a 10 by 15 centimeter mesh, then you already have an overlap at the sides of about 3 centimeters, correct? For 10, so 6. And on top and the bottom, you have a 5 centimeter gap. However, if you consider the mesh to defect ratio, the defect of a 4 by 5 centimeters is about 20 cubic centimeters. However, the mesh, a mesh of a 10 by 15 is about 150 cubic centimeters. So actually, you do not reach the 16:1 ratio. You're only hitting about 7.5:1. That is why right now, you have to consider about suturing the mesh. That's where IPOM Plus came in. So we suture the defect, not suture the mesh, suture the defect to make it smaller. So if you're able to suture the defect so that the defect from 20 cubic centimeters becomes 9 cubic centimeters, then you get the ratio of 16:1. Still get me? That's a little bit of math. Okay. So next is closure of the defect. There have been conflicting studies with regards to abdominal function and aesthetics, but there hasn't been a general agreement with regards to the necessity of closure of defect. There have been several techniques to close the defect. Some would use figure of 8, lacing, use of barbed sutures, use of sutures, passers, and tiny incision to tie the knots. However, there were 6 studies that compared fascial and non-fascial closure, that there is a higher incidence of seroma formation for non-fascial closure. They reported it as 2.5% for fascial closure compared to 12.2% for fascial closure. Seromas are actually managed conservatively in most of the patients and in most asymptomatic patients. However, if you want to manage it, you can actually do serial aspiration. And for recurrent seroma, you may need even to do excision of the seroma lining. Next, we want to talk about fixation. So the fixation should be appropriate for the defect's location, shape, and size. So tackers, there are different ways of fixation for the mesh. You can use transfascial using non-absorbable sutures, or you can use tackers. With regards to this, in the past, there was no math to this one. However, there's already what they call as a mesh to tack ratio. So the ideal mesh to tack ratio based on studies and publication in surgical endoscopy was about, it should be 4:1 or less, 4:1 or less for IPOM plus. What does that mean? So we'll talk about another mesh again. So in a 10 by 15 centimeter mesh, the area, because 4 it means 4 cubic centimeters, so one tacker for every 4 cubic centimeter. So if you talk about a 10 by 15 cm mesh and you use only one tacker is like 25, so 25. But if you consider if you want to reach the 4:1 ratio, you need at least 37.5, if my math is correct, 37.5 tacks for 150 cubic centimeter mesh. So you need 1.5 tackers. Okay. Now next will be the postoperative considerations, pain management, seromas, mentioned it earlier, postoperative ileus, enterotomies, whether the enterotomies are recognized intraoperatively or delayed enterotomies. Delayed enterotomies may require bowel repair, resection, diversion, depending on amount of soilage. Surgical site infection has a low incidence, and cellulitis in terms of infection can usually be managed by short course antibiotics. In cases of mesh infection, mesh salvage can be successful by a combination of antibiotics and percutaneous drainage. However, if the patient becomes septic, then excision of the mesh should ideally be performed. I'll try to show you a video. This is how I usually approach ventral hernias. So I prefer to use an optical trocar. And this is how it looks. So it goes layer by layer. So it has a small blade. So you can see that's the anterior rectus sheath. And then we cut. The small blade can be activated to cut the still anterior rectus sheath. And this is a visiport. Then we cut through the rectus muscle. And then now we're approaching the posterior rectus sheath. And last would be the peritoneum. There. Then we're inside. So it depends on, but what's important is there's direct visualization as the trocar is inserted. Here we're reducing the hernia, reducing the contents of the hernia, which is just omentum. So this one is actually an umbilical hernia. So it's a relatively straightforward procedure, and it's like an IPOM plus, because we don't want any seromas, and sometimes that's why a finger was placed in, because it would be aesthetically more pleasing rather than have a seroma which is still bulging. Nothing's gonna come in anymore, so we just close the defect. So here we use a figure of 8 non-absorbable Prolene 2O suture. After which, suturing. It was elucidated on how to put and remove the needle. Very well lectured by Dr. Roble yesterday. So these are the transfascial sutures. There are some meshes where they don't have the transfascial sutures. I usually put 1 or 2 so that it's easier to put the mesh, make sure that it's right where you want it to be. And now we put with regards to the tacking. So the tacking that we usually employ is called a double crown technique, wherein there's an inner crown and an outer crown, or outer ring and an inner ring. So you can see that there's an outer ring, and then now there's an inner ring. Okay. So relatively straightforward, but you can see the mesh to tack ratio is not very good. The mesh to defect ratio in that instance is quite good, but the mesh to tack ratio is not so good. I'll show you another video before we end this lecture. This was a video. I'd like to thank Dr. Gomez for preparing this video. So this one was a very recent patient. This is an incisional hernia patient who underwent a gynecologic procedure, cesarean sections, 2 of them and a hysterectomy. You can see that there's quite a defect. This patient, one consideration about this patient is the BMI is 48. So she's very obese, and it was quite difficult to suture or to apply the suture. So you can see that the defect, where's the, I mean, like now it's gonna identify the defect, and you can still see the sutures from the past. So there's actually two defects. One is lower down and one is near the umbilicus. As you can see here, we used as what we call as a lacing technique using non-absorbable barbed suture. The defect, you might think that the defect is way up, but it's actually, the defect starts from that area because this is still fascia. So we tried to close this one because it created a pocket wherein the omentum could go in. So you could see the difficulty in putting the sutures. So these are closing the defect and making the defect smaller gives us a better ratio. With the barbed sutures, sometimes what I do is I put a hemolock just so that we could tighten or hold it temporarily. And then apply more sutures, and then you can just tighten everything after. And use hemolock actually to also lock the barb suture. So you can see that we could make the defects smaller. There's no more hole that you could see through. And of course, the barb sutures, if it's under tension, doesn't really hold that well in reality. So it's either you make another suture, knot it, or put hemolock to make sure that it doesn't run away. For the umbilical area, it was a fairly small defect, about 1 centimeter. So we just sutured it close using non-absorbable monofilament suture. We'll try to move a bit forward so to make things. So now these are putting the transfascial sutures. We can support, as you put in your suture passer, you can support it with an instrument inside so that you don't inadvertently puncture any bowel. That's another one. So the superior portion, just try to go through it. So now this is the fixation of the mesh using absorbable tacker. Of course, you can use absorbable or non-absorbable. However, the non-absorbable in the past was associated with some lawsuits because it apparently causes pain. So then you have to consider with regards to this one, this is about a 10 by 15 centimeter mesh. So if you want to do the math and do the ideal mesh to tack ratio, then ideally you have at least to use about 37 tacks, 37.5 to be exact, but 37 tacks. What we use, as I mentioned earlier, is a double crown tacking method. Okay. So in conclusion, patient selection and preparation is very important. You have to consider the size, location, and the circumstances regarding the defect, use of appropriate mesh and fixation, know and anticipate the possible complications, avoiding them. Know your limits. If these are like huge hernias, give them to Dr. Ong, Dr. Chua. So, I'm just kidding. Dr. Villamor, they are very much capable of managing those huge with, there's already a loss of domain. So what's important is to know your limits, to be on the safe side. Thank you for your kind attention.
Thank you so much, Dr. Roselio, for sharing your expertise with us this morning. And thank you so much to our esteemed lecturers for your valuable knowledge and insights shared with us this morning. At this point, we would like to open the floor for questions. We encourage our participants to direct their queries to the specific lecturer you wish to address, so we may have a more engaging and fruitful discussion.
Uh,
Good morning. Congratulations, Don. Wonderful lecture, very clear, very simple enough, but actually for a complex problem. So I'd like to ask you, how do you measure the mesh size? Is it when the abdomen is slightly deflated, or because when you do a pneumoperitoneum, it's usually stretched, right? And sometimes when you do the transfixation already, the mesh will be um, crumpled within. So is it you reduce the peritoneum pressure, intraperitoneal pressure when you measure, or pre-op, do you measure it according to the circumference of the external abdomen?
No, Doc. Actually, we make the measurements preoperatively. You can use, if the patient is very thin, you can actually just measure it, the defect, and if it's quite obvious. But ideally, the measurements are done through imaging. So usually in the CT scan, if you have a CT scan, usually or the ultrasound, they'll say you have a 2 centimeter defect. So there's no pneumoperitoneum yet. That's why they said there's also shrinking of the mesh. That's why sometimes the defect becomes bigger when you insufflate or when you stretch the abdominal cavity. That's why there's a mesh to a defect ratio, because it's actually, it seems to be, so as I mentioned, it's like before you just say 3 centimeters. However, you have to put into consideration the shrinking of the mesh. You say 5 centimeters. Now they avoid those, and they just talk about the mesh to defect ratio. So that is actually, you could measure those, or you could get those prior to the procedure. And then intraoperatively, so if you could see that your defect, let's say, as I mentioned earlier, is about 20 cubic centimeters, you try to reduce it so that you get the ideal mesh to defect ratio. So for a 10 by 15 centimeter mesh, that's 150 cubic centimeters. You ideally only have a defect of about 9, 8 or 9 cubic centimeters. So if you have a 4 by 5 centimeter defect, and then when you insufflate, it becomes 5 by 5, that's 25. So at 25, you will not get the ideal mesh to defect ratio. You have to suture it close or use a bigger mesh if you don't intend to suture it close.
Another common condition is when you have an umbilical hernia. And my question is, what is your cutoff with regards to when you use a mesh for a umbilical hernia? Because, like, let's say our younger surgeons see seafarers and they're not allowed to, embark, and then so you have to repair the hernia. When do you use primary repair, and what's your choice? And when do you use mesh repair, and how would you do it?
If we base it on the recommendations right now by the International Leg Hernia, as I mentioned earlier, they suggest putting a mesh on all hernial defects. However, if we try to go back to history and, like, which ones will require a mesh? We know that it's more than 1 centimeter. So less than 1 centimeter, there have been studies in the past wherein primary closure of defects less than 1 centimeter using non-absorbable monofilament. I usually use I'll mention brands. Proline 1, or if there's no Proline 1, then we'll settle with the Proline O. And you put them not too far from the edge, just the same as just a fascial closure. 0.5 cm from the edge, 0.5 cm apart. Don't put them too far apart. As long as you could close it, the recurrence rate is actually low. But for defects more than 10 millimeters or 1 centimeter, if you do primary closure, we know that based on the past studies, and you'll be asked this in a board exam, what's the recurrence rate? It's about 30 to 35%. And with the mesh repair, it's only 1 to 2%. So you can just think about it. No, so for more than 1 cm, stick with mesh repair. Less than 1 cm, maybe you can just do primary repair. However, with regards to the International Hernia Society site now, they suggest mesh repair for all hernias.
Thank you so much for that fruitful discussion. The floor is still open to more questions, if any.
Good morning. For I just want to, is Dr. Lo still around? I think he's not. Anyway, if anyone can answer na lang siguro, Doc. In the TAPP, how do you know which, when we're about to open up the peritoneum, what is our landmarks to say that this is where we will make our incision of the peritoneum?
So the landmarks are set outside. So if you go and somebody does a proper, when we used to teach hernia repair and TAPP, what I used before was to elucidate and show the whom I'm teaching to, or if I do a live demo, who I'm showing that what we actually, what you see is a dome. So from the anterior superior iliac spine axis, I usually measure 3 centimeters medial. And what I used to do is I puncture a needle through. And then from the midline, you just imagine a line outside. It has to be straight because you want to keep it at that level. You want to put your mesh at the anterior superior iliac spine. And you puncture another needle at the midline. And you puncture another needle near the median umbilical ligament. If you do that, you can actually see that it's curved, because in reality, the inguinal floor is a dome. So it's like this. So if you use a preformed mesh, because there are preformed meshes available, right? So preformed mesh, when you put them, they're actually shaped like this. They're preformed. They're not the flat mesh. If you use a flat mesh, of course, it looks flat. But when you put it inside, it will always wrinkle because they're not preformed. There'll always be a wrinkle at the bottom. But when you use a preformed, it will be shaped like this. So when you ask again, where's the landmark? It's set actually from outside. That's why he mentioned about making burns. So it's actually, you can see that when you do it, it's going to be a bit curved. Okay, so it's a straight line at the level of the anterior iliac spine. So from here, when you put the mesh down, it's actually, it's a straight line from the level of the anterior superior iliac spine going all the way down to the abdominal floor.
In addition, in addition to what Dr. Celio said, no, that's right. It's actually a straight line. But once you're inside the abdominal cavity, once the insufflation is ongoing, it becomes sort of curvilinear when you look at it. But once you deflate, that becomes a straight line. So a SIS to the midline of the abdomen. So basically, if you have patients with bilateral hernias, you will have two incisions on the peritoneum. So just imagine that it's from ACIS to ACIS. Okay, so if you're doing a unilateral procedure, it's still the same. It's ACIS to the midline, which will connect into a straight line to the opposite ACIS. Now, there's a paper published by the group of Edward Felix that's basically becoming the gold standard now when they publish the golden rules of inguinal hernia repair. So if you take a look at that, there are specific instructions on how to do a laparoscopic inguinal hernia repair, whether it's TAPP or TEP. These are the same exact landmarks that you will see. The difference is that when you're doing a TAPP, you have to have that at least 3 cm overlap, but in their paper, it's at 3 to 4 cm. But you should not limit yourself to that only. If you're dealing with much bigger hernias, then you do not basically follow the ASIS. You have to measure at least 3, 4, or even higher, bigger overlap area. So you can actually incise your peritoneum at 5 cm above that inguinal ring, that defect, if your defect is also big. It also plays a role if your patient is tall, Caucasian, or yeah, tall Filipino. Anybody who is a lot taller than usual, then with a big hernia, then you have an allowance to put in a bigger mesh also.
Thank you so much, doctors. And we have one question on our online platform. The question is, do we use RD ratio or carbonyl ratio in assessing ventral hernia? And how does it help?
Can you repeat the question, please?
How do we use, do we use RD ratio or carbonyl ratio in assessing ventral hernia? And how does it help?
What do they mean by RD ratio? I'm not so familiar with RD ratio. Maybe Dr. Roble can answer.
Radius diameter, doc.
I think they're talking about the rectus to defect ratio. So yeah, when you're assessing on you're actually assessing it on the CT scan. So your rectus to defect ratio tells you if you can close the midline primarily, or if you need to do a component separation technique. So if the defect is too large compared to the length of the both rectus, so on the CT scan, we don't have a picture of the image. On the CT scan, you can see both in a ventral hernia is the rectus is far from the midline. So your goal here for ventral hernia is to bring that rectus back to the midline. And there's a purpose for that. Is number one, of course, that's what your repair should be, and number two, it's physiologic that the rectus should be in the midline because that's how you generate your intra-abdominal pressure. So on CT scan, you would add both the rectus, length of the rectus on both sides, and compare it to your defect. If the defect is too large compared to the both rectus, that would tell you that you cannot close that defect primarily. So you need to do a component separation technique, either a transverse abdominis release or an anterior component separation, in order to close that midline. So that is determined preoperatively. No? So that's the importance of doing your imaging study prior to doing your ventral hernia repair, especially for incisional hernias or very large defects. No? You need to visualize that so that you can anticipate your surgery preoperatively. No? Because if you open up the patient and you can't close the midline, you'll have to do a component separation technique, which is a whole different lecture. I don't think it's part of the scope of this workshop. In order to close that midline back and put the mesh over it.
One question for both for the experts here in this room. So I'm sure our young resident or trainees here would want to venture if they're, has accumulated a lot of cases already into hernia repair. And one of the difficulties of hernia repair, and we suggest that they do tap, right, rather than TEP. You think so? Yeah. So it's a matter of choice, but for ease of anatomy, it would be tap. So one of the difficulties there is developing the peritoneum. And in developing the peritoneum, either if it is a secondary repair or it is a primary repair, but somehow due to some inexperience, the peritoneum gets rents, lots of rents. So that is emphasized that you should be very careful. Nevertheless, it happens. Aside from primary closure of those rents, what do you suggest that we use to cover defects and so that the mesh will not be in contact with the intestinal contents?
Thank you, Dr. William. So, the first thing you need to do when you start embarking on hernia repairs is to prevent those rents. Whether you're doing a TEP or TAPP, you need to be able to prevent those rents, and there's a required bit of expertise on how to handle those tissues. And you have to remember that the layers in that abdomen, that area, is not just the peritoneum. You have your transversalis fascia, and there is a pre-transversalis fascia plane. And your transversalis fascia is actually two layers. So there are a lot of things that you need to master first. So meaning you have to know the anatomy, and that when you do a TE, inguinal hernia repair, zone 1, you have to dissect in the pretransversalis fascia area. And on the other side, in the bogros, you have to dissect on the preperitoneal space. So those are very minute differences, but they play a big role in the differences. So you have to be able to master those at first. Now, next is how do you repair those rents in case you, other than the suturing. So the sac is very important. No? So if you can dissect the sac, reduce the sac, or preserve a lot of those sac, you can actually just use that sac to cover those defects. Now, another solution would be to use your omentum to cover. And in some extremely rare instances, you can actually flap those, create some sort of pedicles to cover those. No? A worst case scenario, if you really have no more peritoneum to cover that mesh, then use a double-sided mesh, a composite mesh. Still in TAPP, at least most of it is covered. Maybe a 1 inch diameter defect is there, but at least you kind of covered it already. Now it's less chance of adhesions, but still try to put omental cover on it.
Thank you so much, doctors. And we have room for one more question.
Another that you could use is the median umbilical ligament. I think Dr. Villamor mentioned it here where we were talking. So some patients have huge median umbilical ligaments. It's redundant, so you could use it actually to cover the defect as well. Okay, you could flip it laterally, so to cover the defect. You have to think about defects and hernias. Some hernias, you think of them only as an inguinal hernia, but there are some inguinal hernias which actually extend superiorly, and they're already considered as abdominal wall hernias or ventral hernias. So it's a combination of both. So I think Dr. Henry Chua also mentioned that you need to have a overlap of about 4 to 5 centimeter. So some inguinal hernias actually extend, I'll mention it again, superiorly. Some of them will extend lateral to the rectus. So that's already a combination of and some of them will have, we've seen direct inguinal hernias, which are so huge, they extend superiorly and about 8 centimeters superiorly. So in that case, when we talked about how you open the peritoneum, that will make a difference on how you open the peritoneum. Okay. And you cannot use just a single mesh for those. You might use a very huge mesh, or you can overlap meshes in some instances.
Thank you so much, doctors. Well, if there are no more questions, we will now proceed on with our program. May we kindly ask everyone to take a few minutes to answer our post-workshop survey because your feedback is very important to us in making future workshops even better. So we're lacking a few responses. Kindly answer the survey so that we may be able to provide better future workshops in the future. So you can scan the QR code being flashed on screen right now, and it only take a short while. And as of now, we only have 3 more lacking responses. Thank you so much for taking the time to answer the post-workshop survey rather. And with that, we conclude our video masterclass. I'm sure we've all gained valuable insights into the different applications of laparoscopy in various surgical cases. Now we move on to one of the highlights of today's program, the live surgery session. This is where we see surgical skills applied in real time from incision to closure. We are honored to have Dr. Adrian Patrick Gomez lead this session, along with Dr. Vincent Matthew Roble II as the commentator. Let us all give them a round of applause.
Tama. Good morning, Dr. Roble.
As we navigate through the platform, you may take this time to refresh, take some snacks, or have a bathroom break as well.
Hello.
Hello, hello. Hello, test one. Test 1, 2. Okay. And now, live in Cebu Doctors University Hospital. Endo Alpha Suite. Fluorescence guided laparoscopic cholecystectomy. Possible open. Wala na, okay na. Hello. Test 1. Test 1, 2.
Hello.
Hello.
Morning. Hello,
Good
Russ.
morning, Kuya Vin.
Kuya Russell. Good morning.
Can you hear us?
Yeah, we can hear you clearly.
Okay, so is it okay if we start?
Yeah, go ahead. Can you give
Okay,
us
so
an overview of the case?
okay, so we have here a 57-year-old female, a hypertensive, non-diabetic. 2 years prior, she had an incidental finding on annual screening of incidental gallbladder polyp, 0.3 cm in size. But on follow-up surveillance, it was noted that the polyp was growing now approximately 0.8 centimeters. So we will be doing an elective laparoscopic cholecystectomy with fluorescence guidance. So 5 milligrams of ICG dye in 2 cc sterile water was already given earlier at 9 a.m. So we have here our team. Our lead surgeon is Dr. Adrian Gomez, our fellow in training, assisted by Dr. Joshua Cortez, the chief resident. Second assist is Dr. Villafuerte, our senior clerk, and our scrub nurse, we have Miss Sab, and circulating nurse is Miss Jilly. So, Dr. Gomez,
Okay. Hello? Hello, Dr. Roble,
Okay,
can
go
you
ahead.
hear us?
Yeah, we can hear you.
Yes,
Good
yes.
morning.
So actually, we already started with the trocar insertion. But before we start, I would like to let the audience see. So this is our the endo alpha suite, the Potenciano Villarazabal combined endoscopic and laparoscopic suite. So this is the first X1 and S700 Okay. So this is the first in the region in Southeast Asia, the X1 and um, S700 integrated OR. So this has a second floor, a viewing room for audience or some students or lecturers to look at the surgery live. So here, okay. Are you, Dr. Roble, are you able to see
Yeah,
the?
we can see. Can you show us around the room?
Yeah, yeah.
How large? Oh,
So
there's a
here,
label
this is
there.
our anesthesia machine, our ESU, and behind Joshua is the OTV S700 and the light source and insufflator. Okay?
Okay,
Sige.
thank you.
Okay. So as with any laparoscopic surgery, the first step is to do a diagnostic laparoscopy. In this case, we assess the if there are any bowel injuries. As you can see, there are no bowel injuries. Next is we assess the status of the gallbladder and do a limited diagnostic laparoscopy. Assess the pelvis, the liver, the falciform ligament, okay, and then the other side. Okay. And then we reposition the patient. Can we do a head up and right side up? And insert the working trocars. Okay. So for our first trocar, we insert it at the subxiphoid area, no? And we locate the edge of the liver. Siph, we our landmark is the xiphoid process, and then we insert around 2 to 3 finger beds below it. Lagi. So inserting the trocar, it has to be in a controlled and twisting motion. And next, we assess the gallbladder and insert the other trocar. Yeah, hot water.
So for our residents here, no, since we will be positioning the patient in a head up, right side up, make sure that the patient
if you have any questions,
no,
Okay.
strapped to
hello,
the
hello,
to
wala
the
lagi.
table, no, so that it won't fall.
Hello,
So
hello,
the patient won't
hello,
fall.
hello.
Yeah, go ahead. We can hear you.
Okay. If you have any questions, feel free to course your questions to Dr. Roble.
So what are you planning to do here? How many ports? Is this going to be a 3-port or a 4-port technique?
Dr. Gomez.
Okay. So we're planning to do a 3-port technique. We actually the choice of the technique that we're going is it whether a 3-port or a 4-port, it actually depends on the comfort level of the surgeon. As long as you can actually do it safely. for either 4-port, a 3-port, or a single port. For this case, we're planning to do a 3-port technique. Okay. So, but this is one of the things that I've learned from my mentors. No, so even though we're doing this 3-port, you can actually view the gallbladder in a 4-port technique viewing. No, you just have to with the Maryland, you grab the fundus, you push it on the right side, the liver, and then on the right shoulder, and then using the grasper on the left hand, you can actually view it like a 4-port. See, so then
Yeah,
that's the interior view. This is the posterior view. Okay,
yeah, with
so
that view, can you give us already your landmarks so that
yes,
the residents can
okay.
see?
Okay, so with this view, let me hold this first. Okay, so our landmarks will have to be the sulcus, which is this one. The sulcus, the first part of the duodenum, the CBD here, the junction of the cystic duct and the R4U line, and then the pulsating common hepatic artery. Okay, so before we start dissecting, we would like to ask if maybe we can do an ICG first.
Yeah,
Can
so for the
we?
residents, yeah, before you
Ah,
start dissecting, you always uh do your landmarks. No, before you start dissecting,
eh,
always identify your landmarks before you do any dissection.
IR mode, please. No, there. So, Dr. Roble, can you see that? Yeah, Dr. Roble.
Yeah, we can see it.
Yes, yes.
It's
So
on
actually,
the
we
screen.
injected ICG around 9 a.m. this morning. So this is the liver. Obviously, this is the CBD here. CBD. I think this is the common hepatic, and then we have the 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 cystic duct here. Okay. Okay. Can we go back to our normal view? Okay. Mm. Okay. Audrey. So first of all, before we start, this is what I learned from Dr. Lucelio. No, the where on actually it's not he's not fast, but he just knows where to open the peritoneum. So is it A, B, or C? So it's usually on the B, on the junction where the cystic duct or the infundibulocystic junction. Okay, so we open the peritoneum. We open the posterior deperitonealization. So as you can see, I'm actually not I do not engage my ESU when I cannot see the, can you zoom in? Yes. When I do not engage my ESU when I cannot see the silhouette of my hook. So this means that it's only the peritoneum that I am dissecting. Okay. So there.
So as you can see here, Dr. Gomez is constantly applying countertraction to provide tension and also easier dissection using the monopolar cautery.
Yes.
Otherwise, without the tension, the tissue would only coagulate and not separate.
So again, if you try to observe this, I dissect about 0.5 to 1 cm from the liver edge, because if you dissect too near the liver edge, this usually will bleed. Okay, so that's one of the tips I got from our mentors. So you see this, I think this is a fairly constant vein right here. So you have to cook it. All right. And then next we move to the an- anterior portion, or anterior deperitonealization. Okay, Maryland. So our goal here is to make this triangle or make the triangle of Calo or widen, make this flat and wide. So sometimes, what I usually want to do, because in three part, this fundus right here is obscuring the view of the triangle of Calo. What I do is I like to dissect first this one. Now, if we dissect this one out of the liver bed and then we roll this fundus to the lateral portion. Do you agree with me, Dr. Obenza?
Yes, go ahead.
So let me show you. Let's zoom in. So this is one of the differences in the three-port and four-port technique, because in four-port technique there's that extra instrument retracting the gallbladder um towards the right shoulder of the patient. So
So to reiterate the starting, no? So the way the where you start your dissection should be at the infundibulous cystic junction. If you start it too low, then you're going to be near the common bile duct. If you start it too high, then you have to peel off a lot of peritoneum going down in order to expose the cystic duct. So to make your life easier, make sure that you identify where the infibulocystic junction is
silang.
before you start your dissection of the peritoneum.
So again, this is what I wanted everyone to see. Now, when you release this top portion of the fundus, this fundus right here relaxes and rolls to the lateral portion of the lateral portion, thereby not obscuring your view. Okay. So next when you see this is what Dr. Chua always tells us, no, that you have to make this flat and widen the triangle of Calo. So right here we have our CBD, common hepatic duct right here, as as seen in the ICG. So if the audience has questions, I think Dr. Obenza can uh, answer it for me.
Kuya Vincent, are there any questions from the audience?
Do you have any questions?
So that technique of showing
None so
the,
far.
the
Maybe the
tip of the
mentor has
monopolar cautery is
questions.
very, very helpful.
Gallbladder.
No.
Hello? Yeah, there.
Yeah.
So as you can see, this one is the lymph node. So usually what's behind the lymph node is um the cystic artery.
So what are you starting to see there at the back? I think that's the cystic duct
Yeah,
or presumed. It's not yet
presumed.
confirmed.
But I want to go slow right here because sometimes you might nick the posterior branch of the posterior cystic artery. That's troublesome. Uh, I think kanino.
Yeah.
Interior.
So it's actually good practice, no, to when seeing these structures, we do not immediately label them as the or presume as the artery or even the duct. So we were taught that we only label them as tubular structures, okay, until we dissect the triangle free of the fat and achieve the critical view of safety. Later on, we will be doing the Palace zero BDI timeout when Dr. Gomez has achieved the critical view.
So as you're dissecting there, you already have your ICG available. You can actually alternate turning on your ICG so you
Okay.
can check your position of the cystic duct and the common bile duct periodically. No? So
Okay.
there, yeah.
So this
So
is actually already the overlay mode for the ICG.
yeah.
Hello? Can you hear me, Doc?
Yes.
Yes. So this is the ICG mode, and then we have the common bile duct here, the common hepatic duct here,
Yeah.
the cystic duct, the presumed cystic duct right here. Okay. So can we go back to white light?
Go back to
So I guess you're starting to dissect already the cystic plate of that area. Mm.
okay, roll goes.
We're going to insert rolled gauze for this one. Um, just to control the bleeding, but I think it's a portion of the liver or maybe the posterior side of the gallbladder.
So sometimes in your cystic plate, you actually see the posterior branch of the cystic artery going there. So sometimes that would cause some of the bleeding. So if you're going to start dissecting the plate, you should start your dissection near the gallbladder.
Yeah.
If you're going to have some bleeding, you can
Yes.
always apply pressure. No?
Yeah.
Sometimes those small bleeders will just stop on its own. Small oozers.
So,
So just
so
apply
for
pressure. So you don't have to be worried about it too much.
So this is actually there are a lot of options actually to control the bleeding, but for this one, a direct pressure to the site. Most probably, this is the liver where this is a traction injury. Um, so yeah, I'm planning to. This is what I learned from Dr. Chua.
Room.
Put the gauze in between the put the gauze in between um the window, the stick structures there.
So Dr. Roble, can we have a question?
Yeah.
In your personal experience, with regards to bleeding, no, not non-pulsatile, non-arterial, uh, do we usually go for using like monopolar or energy devices or apply pressure? And because sometimes trying too hard to control these bleeders would uh, delay the surgery. So
Yeah.
do you use pressure or um, energy
I
device?
usually use pressure first. Sometimes I don't even use the gauze. I just use the pressure from the gallbladder. Just push it, uh, and wait for a few minutes. No, wait for the patient's clotting time and bleeding time to take effect. No, um, if there's really a bleeder where you need to ligate, then that's the time I would probably use an energy device or. But but important part is you need to identify the bleeder first. And if you cannot identify the bleeder if there's a lot of blood in your field. So you need to clear out the
Then
blood in your field. That's why you have your gauze, your suction irrigation before you attack the bleeder itself. No, so blind ligation, blind clipping, or your or using your energy device without really identifying where the bleeder is. It's not safe. No. So clear out first your field, like what Dr. Gomez did just now, and you see a clear field already, and then that's the time you would control the bleeder. No, so see the bleeding that stop on its own, just by applying the pressure of the gauze. No, so there's no need for any fancy energy devices yet.
Okay.
Yeah,
So
Dr.
Yeah, I'd like to comment because one of the sessions yesterday there were questions about when you're trying to dissect for the cystic duct and the cystic artery, wherein you don't open your Maryland to dissect. So as what you observed earlier, Dr. Gomez was trying to dissect the cystic duct and the artery using the Maryland by closing and opening it. But as if you want to be safe, want to be parallel to the length of the cystic duct and artery. So you can do it, but as long as you do it slowly and carefully, because you don't actually just stab and look for the plane. You can actually try to dissect.
So Dr. Gomez, what our next step?
so actually so this in this step we're actually in the critical view of safety. We're actually ready to clip. Prior to clipping, we have to identify the key structures. No, so we have the duodenum, the common bile duct, the two tubular structures going inside the gallbladder. We have the presumed cystic duct and cystic artery, and then we have the common hepatic duct here, and most importantly, the cystic plate, which is about 1/3 of the gallbladder fossa.
Okay.
Yeah,
So
can you show the residents what they mean by flag waving
Okay.
or the flagging, so that they
Okay.
will understand what that maneuver means?
So flagging is when you see two tubular structures in the anterior and posterior view. So example, for this one, this is the anterior portion. There are two structures going inside the gallbladder. See that? And then when you do, this one is the flagging. When you do when you view it from the posteriorly, you see two structures also. So the presumed cystic duct and cystic artery. So see there.
So at this stage, I
So
guess you're ready to call the bile duct time out.
yeah.
Okay.
So
So are all the important landmarks identified?
yes.
Are the criteria for the CVS in doublet view achieved?
Yes, I think we already
Okay.
did that.
So you already enumerated and showed the structures earlier.
So this
So to the surgical team, Dr. Cortez and our scrub nurse, do you agree that what Dr. Gomez is pointing to is the cystic duct?
cystic duct. Then okay, so I think we're ready
Don't forget to.
ready to clip. So before clipping, we would want to milk the cystic duct for possible stones. Okay. And then
Probably
ready.
better to show the ICG view again,
Okay.
just
Yes.
to maximize your ICG.
Yeah. So let's see in IR mode. See? So this one is the CBD, the one that we're going to clip. This one is the cystic duct, right? Gallbladder. So the one behind is the cystic artery. Can we go back to white light again? Okay.
Very good dissection done by Dr. Gomez here.
So
Can we have a show of hands of the residents? In your respective institutions, do you use the Hemolock plastic clips, or do some of you have experience on using the titanium clips for clipping
thank you.
the the two structures? Can we have a show of hands who uses Hemolock clips? What? Yeah. What about titanium clips? Have any of you had any experience on using the titanium clips, the multiplier?
Yun ko lang. Yun ko lang.
I guess majority already prefer to use the plastic locking clips.
So the recommendation Palace is to have two clips on the cystic artery and also two clips at the cystic duct. So basically, it's doubly ligated. And then shears.
Mag-click tarong, dugo na ng dugo. Tayo. Kateriya na. Wala niya mag-click.
Okay. So this is one of the techniques Dr. Chua always emphasizes to us. You have to you have to relax the left hand, or you have to Yeah, and this is mentioned earlier by Dr. You have to relax the left hand prior to clipping. This will allow for avoid tension or tenting of the cystic duct. So you see, very it's not tented. Okay.
So when you're clipping the cystic duct, you relax on your tension on your left hand so that your common hepatic and your common bile duct won't get tented. Mayu siya ba? So sometimes if you pull it too much, you might ligate also the common hepatic duct. You know? So you relax it so that it would straighten out and you would clip only the cystic duct. If you pull it too much, if you imagine you pull it too much, it's gonna go like this. No?
I don't know.
And you might clip it here. So relax it so you can just clip the cystic duct. No?
Can you show me the edge? Oh no.
And for Hemolux, you have to make sure that there's a lock at the other side. It has to be able to surround the whole tissue.
There. So the last portion to dissect the gallbladder from the liver bed. Yeah.
So usually for beginning laparoscopic surgeons, the problem of depth perception is very common. No, sometimes you think it's near, but it's actually still very far. So when you're doing this cautery, some surgeons, especially the beginners one, would activate the cautery even before it has reached the tissue. That's what Dr. Yu was mentioning yesterday about open air activation. So the danger of that is you might hit another structure, or that's what we call capacitive coupling, where you're charging actually your trocar, and your trocar hits another structure and causes burn. So if you're beginning and your depth perception is still not developed yet, my advice is don't activate the hook dissector yet. Touch the tissue first, and once you feel that you have touched the tissue, that's the time you activate your hook, your cautery, electrocautery machine. No, once you've developed it, it becomes natural. But when you're still starting, it would help to touch the tissue first, then do the cautery. No, if you don't touch it yet, don't activate the cautery yet. No.
Hello? Okay.
Yeah, go ahead.
Yes,
Yes,
Dr.
you
Roble.
removed the gallbladder already.
Yes, I actually agree with what you said. You have to touch the tissue first before activating, because this can cause injuries to nearby structures. Okay, so we actually inserted a modified retrieval bag um, for, for our gallbladder extraction. So what we're planning to do is to extract the gallbladder from the umbilical cord, but we're still gonna go in, check for bleeders and bile leaks and bowel injury, and clips the integrity of our clips. Okay, so let's okay. So what's that?
Okay, Dr. Roble, are there any more questions from the floor?
Do you have any more questions from the residents or from the consultants?
Because if there are none, we will just be going in later for the removal of the secondary working parts.
Let's go inside. Okay. So it's actually important that if you see this, it's actually important that the abdomen is disinflated before we go in. So this will release the pressure of the insufflation again because of the insufflation pressure. This will impede some of the small. This will act as a um, hemostatic. This has a hemostatic effect.
Parang
So it's
tamponad.
yes, it can tamponade. So it's actually good that you exit you extract the specimen first, keep it disinflated, and prior to going in again. So, and then you see if there are any bleeders or
Those
so again we're inside. Okay. So let's check again our suction some blood. Let's check again um our field. Can we have ICG? Make sure everything is IR mode. All right. Okay. So this one is CBD, the common hepatic duct. We ligated the cystic duct. Okay. Let's go back to white light. We have the cystic duct here and our cystic artery. Integrity of our clips are very okay. No, there are no bowel injuries. So BBB, blood, bile, and bowel. All right. And then after that, we we remove the trocars, the working trocars under direct visualization. Oh no, Dr. Cell is making fun of me. Okay, so before we exit, there are no bleeding, no bleeding. All right.
Okay.
Then
Congratulations, Dr.
uh,
Gomez, and thank you
turn off the
everyone.
insufflation.
Thank you everyone for your kind attention.
Very good dissection, Dr.
Okay.
Gomez. Thank you very much for your demonstration. Are there
Thank
any
you very
more?
much. Thank you.
Thank you very much.
Thank you. Thank you.
Are there any more questions from our participants? If you have any more clarifications or, finer points.
So can we have the surgical camera? So in closing the surgical camera. Okay. Oh, wala na. Okay. So you have to close the fascia um, under direct visualization. So
So for all residents, you need to start practicing your skills on the in your simulators. That would help you with your depth perception, your feel of the instruments, no? And then if you're starting off with the surgery, you choose your patients, no, such as this patient, no. So you start first with the easier, supposedly easier gallbladders, so that you can apply all those critical view of safety principles that you have seen today, no? And that would help you progress to more difficult gallbladders, no? So if you're starting, patient selection is always number one on the priority list. skills, training, familiarization with the anatomy, and patient selection. No? So it's not going to be a race. Not all gallbladders can be done in 30 minutes. Sometimes you get 2 3 hours, probably sometimes even harder. But if you stick to the principles and you know how to troubleshoot, then you're going to do well, no? Ensure that there's the patient's safety. No? Okay. Do you have any more announcements, Dr. Chua?
It's okay. We were just troubleshooting. Because this is the first time this new Endo Alpha was used. We our old Endo Alpha is the first one we had is 2012. No, it's still working now, but this is the new one, so there are a bit of some kinks on how to operate it because it's a totally new system. Now we apologize for the quality of the video. This was supposed to be transmitted in 4K via fiber optic cable, but since we had to use Zoom because there are Zoom participants, so the quality was diminished significantly. But rest assured, if you use the real 4K system, it's super crystal clear. It's unfortunate that we were forced to use Zoom for this, but we could have used the fiber optics. It's already laid down. Now, I think in addition to what Dr. Robles said, forget about speed. No? If you're still starting, forget about speed. Going slow is safe, and going safe is smooth, and going smooth will be fast. No? Forget about speed, and you just realize, oh, you're done. As long as it's a clean, safe surgery, you'll be okay. And whenever you are in trouble, always call for help. Always. It does not diminish you as a surgeon. It will actually benefit you and the patient. No? Okay, so any questions? Are the certificates here? Are the certificates already here? On the way? Okay, the certificates are on the way. Now, whether you use 3-port, 4-port doesn't matter. Okay? Single port, if you're really adept, go ahead. All the literature will tell us, published peer-reviewed literature will tell us there's no difference if you use single port, 3-port, 4-port, 2-port. It's all safe as long as you are competent and you achieve the critical view. Okay? For PALES requirements, before it was 4-port, dapat 4-port, but the new requirements for you to submit videos, there's already an option to do 3-port. Okay? Supraumbilical, infraumbilical, intraumbilical does not matter. Open Hasson technique versus various needle technique does not matter also. If you go to Europe, nobody uses open technique. Everybody uses various. So to say that open technique is superior to various is totally wrong. Okay, the literature and all the published data will tell you they are equal as long as you know what you are doing. Okay, okay, so finally the certificates are here and we can. Okay, okay, so we will now award the certificates of participation to all those who are present yesterday and today. Again, as I mentioned, this is a certifying workshop which you can use to apply for PALES. So with these certificates, you can already start doing your cases. 10 cases assist with a certified preceptor or trainer, and 10 cases done with a certified trainer or preceptor. If you are accompanied by a fellow, that is not acceptable. The one accompanying you must be a fellow and preceptor or trainer. Okay? So, can I ask Dr. Roble to help me on stage? Okay. So, we'll call the ako itawag. Ikaw award. So may I call saan lang ka? When your name is called, please come up on stage and receive the certificate from Dr. Roble, who is currently the trainer